Hello everybody, and welcome to the Virtual Education Chronic Pain Summit Series presented by Johns Hopkins University School of Medicine. My name is Dr. Michael Clark, and you are tuned into the live session called Is the Use of Opioid Analgesics Ever Warranted in the Management of Chronic Pain with Dr. Mark Sullivan. Dr. Sullivan is a professor of psychiatry at the University of Washington. He provides psychiatric consultation services in the University of Washington Medical Center for Pain Relief, with a focus on diagnosing and treating depression and anxiety in patients with chronic pain. Now, before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Also, I would like to thank Lilly USA and DepoMed for their support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits. My name is Dr. Clark. I thank you for joining us. Mark, please go ahead.
All right. Thank you, Michael. Thanks for having me here to speak today. And what we're going to do is look at the question of long-term opioid therapy for chronic pain, especially in light of how it has been implemented in actual practice over the past 2 decades. I think we've moved from the sense that this could be a therapy very broadly applicable to patients with chronic pain to a sense that it likely has a more limited application. And we've phrased the question provocatively today to focus on who, if anybody, is really appropriate for long-term opioid therapy. I'm going to start off with a case. This is an actual case that we were asked to see by our state Medicaid program. This is not her actual name or picture, but this is Mary Twitchell, a 50-year-old white female. And I think the question here is whether this is appropriate opioid use, whether it's simply high-dose use, a form of misuse or abuse. So Mary has a variety of chronic conditions, including type 2 diabetes, obesity, coronary artery disease, asthma, anxiety, and post-traumatic stress disorder. At the time we had our consultation with her, she was taking methadone, 240 milligrams a day, oxycodone, 240 milligrams a day, for a total morphine equivalent dose of 3,240 milligrams per day for multifocal chronic pain, including back pain, abdominal pain, and epigastric pain. In addition, she was taking temazepam, 30 milligrams at bedtime, diazepam, 10 milligrams 3 times a day, dexvenlafaxine, quetiapine, and escitalopram. She was satisfied with her medication regimen, reporting greater comfort and an ability to garden, and accepted the risks that are associated with this regimen, such as respiratory depression. So I ask our audience to keep this case in mind as we go through some epidemiologic data and some of what's known about trends and risks in opioid prescribing. And then we'll come back to consider this case and another one at the end of our talk. So it's important to remember the great promise of opioids. Thomas Sydenham, 300 or more years ago, he was known as the English Hippocrates, stated, "Among the remedies which it has pleased Almighty God to give to man to relieve his sufferings, none is so universal and so efficacious as opium." And I think this is the kind of promise that we entered into the era of opioid therapy with. It's also important that the context within which opioid therapy arose was one where the ethical argument around pain relief, particularly at the end of life, had really already been won. And I've selected a quote from Sidney Wanser. This was an article about palliative care from the New England Journal in the late 80s. And I think it frames the, what I call the opioid interpretation of the ethical responsibility to relieve pain quite clearly. In this article, he stated, "The proper dose of pain medication is the dose that is sufficient to relieve pain and suffering. To allow a patient to experience unbearable pain or suffering is unethical medical practice." And I think this is the way that the challenge of chronic pain care was framed in the 80s and 90s, to be sure. Just as if it was unethical to allow someone to die in pain or to have someone with cancer to be in severe pain, so also was that extended to non-cancer pain, where the idea was that the pain level needed to be driven down. This has occurred against the background of the following scientific argument for opioid treatment. So there have been multiple randomized controlled trials of opioids that have shown superior efficacy compared to placebo for chronic pain conditions. Generally, the opioids produce about 30% more pain relief than the placebo over the 12 weeks of the trial. Effects on function are quite a bit more variable. Oftentimes, just function of body parts was assessed and not function of the whole person or their role function. Now, it's important to know that these randomized trials have demonstrated the efficacy of short-term use of opioids. Like I said, the trials were about 12 weeks, some as long as 16, but not long-term, not years of use such as we are seeing out in practice. And this led one authoritative review by Martel in the Annals of Internal Medicine to conclude that, quote, "the evidence in favor of opioids for chronic low back pain is not always consistent, and when supportive only supports this treatment for short periods. Nevertheless, as we know, there's widespread use of opioids over much longer periods." In addition to this argument about efficacy, there was an argument made for opioids claiming that they were safe. However, addiction risks were initially estimated using inpatient samples and outpatient randomized control samples. These samples all excluded patients with mental health and substance abuse disorders, which have now been shown to be the patients most likely to receive and continue opioids in clinical practice. So one famous paper by Porter and Jick estimated that opioid addiction rates were 0.05% and abuse rates were 0.4%. This was an authoritative reference. It appeared in the New England Journal, and very few people went back to check to notice a couple of things. First of all, it was a letter, not an article, and second of all, it described inpatients, largely cancer patients, exposed to opioids in an inpatient setting. So very different from the kind of prolonged outpatient use that we're now seeing. Recent estimates of abuse and addiction risks are highly variable due to the differing definitions of abuse and the populations assessed. Fishbane in a 2008 review talked about from 0.2 to 3.2 risk of addiction and 15 to 20% risk of aberrancy. Chelminsky looked at a bit higher risk population and found about a third of his sample engaged in substance abuse or substance misuse over the year that he was followed. And at the other end of the spectrum, Fleming looked at a sample where there was nearly 80 to 90% lifetime aberrant behaviors, and that is a broader concept encompassing early refills, doctor shopping, unauthorized ER visits, etc. So our sense of how safe the opioid treatment is has also shifted lately.